Hi, in this lecture, we're going to talk about the stomach. Now, the stomach, remember, is a GI tract organ, part of the alimentary canal. And so once we take the food in through our mouth or oral cavity, we swallow and we send it down the oropharynx to the laryngopharynx, down the esophagus to the stomach. So the stomach sits on the left side of the body. It's kind of roughly a J-shaped organ. So let's look at the gross anatomy of the stomach first. So this is a picture from lab of, this is the one I call Smeagol's stomach. And then we see an overview here as we go through gross anatomy. So understand that the volume of your stomach really depends on how much is in it. So, you may have stretched it quite a bit when you eat, right? It stretches and expands, and when it's empty, it kind of collapses and folds. And the folds that it collapses in are these things called rugae. So you can see the rugae in this stomach here on the inside, these like folded areas. So it's kind of like an accordion. It can stretch and stretch. Now, when we look at the stomach, you notice here's the esophagus. So I'll show you on the picture first. We have the area of the stomach next to the esophagus called the cardiac region, or simply cardia. Either one is fine. The superior portion of the stomach is going to be called the fundus. And then we have the main part of the stomach, which is going to be called the body. Now, if we look at the body, there's two curves on either side of it. There's a smaller curve called the lesser curvature, which is medial. And then there's a greater curvature, which is out here, which is going to be more lateral. The pylorus is the inferior portion of the stomach, and the pylorus will actually meet up with the duodenum of the small intestine. Now, when we're looking at the stomach, the most active portion of the stomach for digestion tends to be down here in the pylorus. And we did talk about two blood vessels that carry blood to the stomach. They were called the left and right gastric arteries. And so on the models, and I'll draw them here, you'll kind of see the left gastric artery runs more on the lateral side, on the greater curvature, and then on the lab models you'll see a little vessel on the inside, which is the lesser curvature, and that is going to be the right gastric artery. So we come down here and we look at the stomach model. We notice we see our sphincter right here. So we talked about having that lower esophageal sphincter. Remember, that's the sphincter that can open up and let food come in, but also if that's weakened, hydrochloric acid can get up in it. So this area here, this line is actually representing the cardia or cardiac region. Either one's fine. And then this kind of whole area here would be the fundus. Now, it's trying to show you the greater curvature. And again, it's the whole curve. And then on the models, there is a red thing there. So we usually label that, let me fix that, as the left gastric artery. And you will see it better when you're in lab and you actually have the stomach model in your hand. But the idea is you find the greater curvature, and that will help you find the left gastric. And then on the inside, we're going to have, remember, the lesser curvature. And you can see this curve. And then the blood vessel there, remember, would be the right gastric. And again, you don't see it great in this picture, but when you're in lab, pick it up. And then we have what's called the pylorus, which is the inferior portion of the stomach. And then this right here, that's a sphincter, and that's called the pyloric sphincter. So the pylorus is going to send food into the small intestine. The duodenum is the first part of the small intestine, and that sphincter is called the pyloric sphincter. So when that pyloric sphincter is open, food materials leave the pylorus and enter the duodenum, and when it's closed, it can't enter. So that's the gross anatomy. Let's look at the micro anatomy. So we have the same four tunics. You can see them here, but notice all the adaptations. Let's look at this simple view here, the mucosa. Here's my submucosa. Look at all the muscle. I have an oblique muscle, a circular muscle, a longitudinal muscle, and then I have the serosa. So the two biggest adaptations that we're going to be looking at in the stomach are going to be when we look at the mucosa layer And then we look at all that muscle. Remember that the stomach does mechanical digestion and it has a lot of muscle in it. So when we look here at the stomach, you can see these like pits here. Like see how maybe we'll start here. What you have are these little openings. So what we're going to have are these gastric glands, and gastric glands make gastric juice. And so these are the glands down here. And you can kind of see different colored cells. And then in this view, again, you can see how it kind of runs down. And we'll have these gastric glands. So the opening is called the gastric pit, and that's, you can see that here, a little circular opening into the gastric gland. Now, the gastric glands are going to have a lot of cells, and so these cells are going to make different substances. So you have the mucus, the parietal cells, the chief cells, and the G cells. So mucus neck cells make mucus. You'll see parietal cells. So we're looking at, again, we have this gastric pit going down. Here's my gland. These are my mucus cells. So obviously they're going to make mucus. And then the parietal cells are shown as kind of green here, scattered. Chief cells, purple. And then they call these DNES cells, or just G cells. They're going to make the hormone gastrin. So we're going to look at each of these in a little more detail. So if we look at the parietal cells, they are going to make hydrochloric acid and intrinsic factor. And so we know that intrinsic factor, you might remember this, that it's necessary to absorb vitamin B12. So B12 is pretty big, and it has to bind to intrinsic factor made by your stomach, and then that's how we get it absorbed. And we need B12 to make red blood cells. So there was a type of anemia called pernicious anemia when we don't have enough B12. So again, the mucus cells are going to make mucus, just what it sounds like. You can see, by the way, this thick layer of mucus here. We're going to have the parietal cells making intrinsic factor and hydrochloric acid. So the way they make hydrochloric acid, this should look very similar to you, okay? First of all, why do we need hydrochloric acid? Well, number one, it keeps the pH of the stomach very low. So they say the pH of the stomach is like 1 to 3. So a lot of times we'll just say it has a pH of 2. And so this protects the stomach. It's a non-specific defense, an innate defense mechanism. So remember, when we swallow cells, the debris and pathogens, when they hit our stomach, they're going to die because it's just so acidic. It does help break down meat, so physically breaking down meat. And it also is critical because it's going to activate the enzyme pepsin from the inactive form called pepsinogen. So pepsin is the active version of pepsin. Pepsin is the active version of pepsinogen. I apologize for that. There's too many P words, because pepsin breaks down protein. Now, let's look at how hydrochloric acid is produced. And you should be remembering this fun equation you just had in your last unit. So we know if we take carbon dioxide and we combine it with water, that we're going to get carbonic acid. And we also know that carbonic acid breaks down into that bicarb ion and a hydrogen. Now remember that the bicarb left the cell when we did this for respiratory, and then the chloride came in. So what we're trying to do is make hydrochloric acid over here in the lumen once we're in the stomach, because hydrochloric acid is so acidic, right? We don't want it inside the parietal cell. So what's going to happen is your parietal cell will take up CO2, and CO2 will combine with water and the enzyme carbonic anhydrase to form carbonic acid. Well, what's going to happen next is that hydrogen that's formed is going to get pumped into the lumen of the gastric gland. This is active transport. There's actually little hydrogen ion pumps, and that's what they do. They pump it out. And remember, the bicarb leaves to go into the blood. Well, when the bicarb leaves to go into the blood, the chloride comes in, and it goes all the way through. So then what I can do is combine my hydrogen and my chloride to form HCl in the lumen, right, in my gastric gland, in my stomach, where it's going to be more protected. So this is how we generate stomach acid. And again, as we do that, we're also getting that bicarb, and it's going out into your blood to buffer. So they just call this the alkaline tide. So what if you have too much stomach acid? What if you have like acid reflux or gastritis and you're having too much acid being produced? Well, we have several lines of treatment. So remember GERD, G-E-R-D, we talked about this briefly in my last lecture, okay, gastroesophageal reflux disease. So anytime we have that reflux where the acids are entering the esophagus, or maybe you have gastritis where you could be forming, a stomach ulcer, there's several lines of defense. So the first thing is kind of the quick ones. These are your antacids. These are your buffers. So Tums, Rolaids, even Maalox, they're like calcium carbonate. And what they do is they just buffer it. So their job is to buffer all that hydrochloric acid and bring that pH back up. So they work pretty quickly, but they don't last long. Now, if you're more prone to GERD or reflux, there's two other mechanisms. There are proton pump inhibitors, and just what we looked at with this hydrogen pump, a proton pump inhibitor is going to prevent that hydrogen pump from working, so you won't make as much hydrochloric acid. So they're going to actually literally block the hydrogen pump. And you've probably heard of some of these meds before. And then there's also histamine blockers. These are antagonists to histamine because histamine, when it's released in your stomach, it increases the production of stomach acid. So these are more longer term type things. They don't work as quickly, but they last for a longer duration. So if you're more prone to GERD, you might take those. Now, everything has risk because we know that we need to have hydrochloric acid, right, for protection and breaking down meat. And so, if you're taking a lot of these, then maybe, you don't eat as much like heavy meats or watch some of your protein intake. Now, the chief cells make pepsinogen, and pepsinogen is the inactive form of pepsin. Pepsin is an enzyme that breaks down protein. So it breaks down about 10 to 15% of the protein in your meal. And so it's critical for protein digestion. So it's activated by that low pH in the stomach. So remember, this is another reason why we need to have a low pH to activate that enzyme. And then we have gastrin, so it comes from those DNES cells, or these are these enteroendocrine cells. So, when we look at gastrin, we just typically, it's called a G cell, which is fine for us. And so this makes the hormone gastrin. So it's a hormone, it's produced by the cell, and then this will go in your blood. And you could probably guess that gastrin is going to stimulate gastric juice production and motility of your stomach. So it increases the digestive processes that are happening in your stomach. So, why do we have a stomach? Well, basically we know that our stomach does a lot of things for us. Number one, it does store food. Food can hang out in your stomach 4 to 6 hours, depending on what you ate. It does do mechanical digestion. So one of the other adaptations that I mentioned was the muscle layer. So muscularis externa or just muscularis. Remember, it has circular, longitudinal, and oblique muscle. So you have all this muscle, which makes it contract really, really hard. I told you previously, when your stomach contracts, it's so strong you can hear it, right? When your stomach growls, that's your stomach contracting. So really good at mixing and churning your food. It also does chemical digestion. So it does chemical digestion of protein with the enzyme pepsin. We just mentioned intrinsic factor, which is critical to form vitamin B12. And it can do a little bit of absorption. Now, we'll talk about that briefly. There's not a lot of absorption in your stomach, but some liquids and some small molecules can be absorbed in your stomach. So when we look at the stomach, there's actually 3 different phases where your stomach activity is affected. So how do we control gastric juice, right? Hydrochloric acid. What's happening here? Well, we know, again, that we're going to have the CNS control. We're going to have the ENS, right, the enteric nervous system, and we're going to have hormones. So remember, when we look at the CNS, that is in control of the ANS, which is my sympathetic and parasympathetic divisions. So there's 3 phases where we can influence our stomach activity, and they're called the cephalic, which you should be thinking head, the gastric, stomach, and the intestinal, small intestine. So the first one is cephalic, and cephalic happens, think about head, it's whenever you see some food or smell it or you taste it or you're thinking of it. So basically, if you're seeing food and you're thinking of food and you're hungry, this only happens if you want the food. It's basically preparing, your brain is preparing your stomach because chances are you're going to eat the food. And so when we're looking at this, we know it's the vagus nerve. And so thinking about it activates cranial nerve 10. And then the vagus nerve goes to the stomach and it releases acetylcholine, and that's going to increase the production of gastric juice. So we're going to increase, all of those cells become active because gastric juice is going to have mucus and pepsinogen and hydrochloric acid and even some gastrin. And so this is our first phase when we think about when we can affect our stomach secretions. Now, it also, in your notes, you have it triggers the release of histamine because histamine is going to increase the production of hydrochloric acid. So we will have more acid. And because this is kind of our brain affecting our stomach, we also know emotions affect our stomach. And we'll be talking about that shortly, but we know that sometimes anger or hostility can have excessive secretions, but a lot of times depression, anxiety, or fear will decrease stomach secretions. Now, let's say that you see a food, you're hungry, and now you eat it. Okay, so the next phase is going to be the gastric phase. This is when food hits your stomach. So when food hits your stomach, it's going to stretch, right? So this has a couple things going on at once. So it's a local response because we have a stretch response. So as it stretches, right, it's going to activate a stretch response, which will increase basically your parasympathetic stimulation. So it's going to increase your vagal nerve, right? Vagal tone. So we're going to have even more of our vagus nerve. We also know that there's chemoreceptors here, and the chemoreceptors respond to the chemicals, and one thing they respond to is the pH. So if your stomach pH should start to go up, that will trigger an increase in gastric juices, because remember that gastric juice has hydrochloric acid in it. So if your pH were to go up, you're going to want more hydrochloric acid to bring the pH back down where it should be. We also know that if you eat a meal high in protein, we know that when we have a lot of peptides or proteins, that tends to buffer and raise your pH. So a higher protein meal would increase gastric juices. And even things like alcohol and caffeine, when you eat those and ingest those, that's going to increase the production of gastric juice as well, and which again would have hydrochloric acid in it and, the mucus and etc. So a lot of times, if you are drinking alcohol, if you drink it on an empty stomach, it can be absorbed in your stomach and irritate your stomach, which is why it's better to have it with food. Now, the next thing when we're looking at our secretions is we also know there's an intestinal phase. So the intestinal phase is, remember, the stomach's mixing the food and moving it down, and ultimately it'll open that little pyloric sphincter and kind of squirt it into the duodenum. So when we're looking at the intestinal phase, this is the first phase that's inhibitory, because the cephalic, right, thinking about food, and gastric, when food hits your stomach, they're always excitatory. You're increasing juices, motility, all of that. But when we get into the intestinal, we're going to start to slow things down. So we have what's called the enterogastric reflex. When you see entero, think small intestine, because this reflex is going to be inhibitory on the stomach. So it's going to inhibit gastrin, and it's going to slow down stomach contractions. It's going to cause that pyloric sphincter to close. And so what happens is the stomach working and it's, mixing everything, and the sphincter's open and it squirts a little in. As soon as food, which I'll tell you now is going to be called chyme. So once your stomach processes all that food that you ate, it turns it into this like white pasty stuff called chyme. So as soon as chyme hits the duodenum, that's what triggers this reflex. So the presence of it hitting the duodenum will slow down stomach contractions, especially down by the pylorus, and close the sphincter. Well, the purpose of this is really to slow things down, because you want food, you want this chyme to enter the duodenum at a nice slow pace for two reasons. One, we need time to digest it because the small intestine is where most chemical digestion and absorption occur. So you're not just going to dump it all in there at once. And two, the chyme is very acidic. Remember, the pH of your stomach is around 2. Well, the pH of your duodenum is around 8. So you want to also make sure there's time to buffer that chyme. So the acidic chyme enters the duodenum and triggers the enterogastric reflex. And then this also triggers the release of hormones. So there's 3 hormones that are released. Now again, the stimulus for release is chyme entering the duodenum. That's the stimulus for the release of these 3 hormones. So we have what's called CCK, we never say its whole name, and we have GIP, and we have secretin. So, and you can see them here. So CCK, when it's released, it's inhibitory. It's going to slow down gastric secretion, right? It's going to decrease the juice, decrease the motility, but it also causes the pancreas to release a enzyme-rich juice, because if all this nutrient-rich chyme is entering the duodenum, you're going to need to start breaking it down chemically with enzymes, and a lot of those enzymes come from your pancreas. Now, GIP is just what it sounds like, gastric inhibitory peptide. So I told you this is an inhibitory portion. So it's going to slow down stomach contractions, decrease motility, decrease production of hydrochloric acid. It also stimulates insulin release because insulin, remember, its job is to bring your blood glucose levels down. So if you're eating a meal, the expectation is that your blood glucose levels will be going up. And then secretin is a little bit different. Secretin is mainly released anytime the pH falls. So when we're looking at the pH, we're looking at the pH of the duodenum. Remember, the pH of the duodenum should be around 7 or 8. So if it starts to drop to 4 or 5, that's the stimulus to release secretin. And secretin does a couple things. It stimulates the release of mucus in the duodenum, so there's a little more mucus to protect it. And it also stimulates the pancreas to release a bicarb-rich juice, because remember that bicarb is going to help buffer. And so if we send more bicarb, we can buffer all that acidic chyme. So this is just an overview. There's 3 phases that affect the stomach. We have the cephalic, when we think about food or see food, right? That's always going to be excitatory. We have the gastric phase, which happens once we eat the food and we stretch the stomach. We're going to increase, again, more vagal tone, more vagus nerve. And again, it's very excitatory. And then we have the intestinal phase, which starts once that chyme enters the duodenum. And most of that is going to be inhibitory to slow things down so that we have, basically we have time to digest the chyme and also to help buffer because it's so acidic. So we kind of touched on this briefly, but you got all this acid in your stomach. So what protects your stomach from digesting itself? Well, we have those gastric glands that have mucus, right? So one of the things that's produced is a very thick layer of mucus. So this layer of mucus protects, it basically coats and lines the inside of the stomach. All the cells here, the epithelial cells, they're joined with tight junctions. Remember, tight junctions, nothing gets between them. So what that does is that doesn't allow any of that hydrochloric acid to kind of come between those cells. So we have our mucus, we have our tight junction, and then if any of these cells are damaged, they're replaced very, very quickly. The lining of your stomach has a very high mitotic rate. I've read that the lining of your stomach, these cells, the whole thing is basically changed over every 3 to 5 days. You have a brand new stomach lining. So very fast mitotic rate. And so, we talked a little bit about gastritis, and there's something called an ulcer. So if you have, too much acid, it can eat away at the lining of your stomach and cause an ulcer. We also know that a lot of ulcers are actually a bacterial infection. So a lot of times you can get tested and then you can take antibiotics and that will help your ulcer go away. So as far as what's happening in the stomach, we've already mentioned these processes, right? So the food comes in. The only digestion is protein digestion from pepsin. Little bit of absorption. You know, as we mentioned, we have this really thick layer of mucus, so it's really hard for anything to get through that mucus to be absorbed. But if it's lipid soluble, like alcohol is lipid soluble, aspirin is lipid soluble, or it's very, very small, then it could be absorbed in your stomach. So some medications are designed to be absorbed in your stomach, and some are more encapsulated so that you don't absorb them until you get into your small intestine. And the stomach is working so hard and mixing and churning the food that it turns it into that pasty-like substance, which is called chyme.
About 4 weeks' time.
And however well-mannered we are about getting food into our mouths, there's not much decorum about what happens next. Food doesn't simply fall from mouth to stomach. Your brain triggers waves of muscular contractions that squeeze things along your esophagus at around 2 inches per second. The first place it reaches is the stomach. It's really a biological blender, a churning pool of digestive juices to break down food into easily absorbable ingredients. Leaving the stomach, things are already unrecognizable. Bile, produced in the liver, is added to help the breakdown of fats. At all stages, the body is extracting the nourishment it needs from the passing flow. The walls of our intestines are a vast surface of cells that absorb proteins, sugars, and fats into our blood. It's these that will provide the energy we need for life.
So hopefully you enjoyed seeing the inside of the stomach workings. And then I want to talk just a little bit more about the motility and the emptying of the stomach. So motility is contractions and secretions, and we've touched on this already, but we know that the strength of contraction is affected by hormones. So we know gastrin, definitely, right? And neurotransmitters. We're looking at acetylcholine when we're looking at the parasympathetic. So those will always increase the motility. We also know that some other things affect our stomach. And so one thing is, basically, what did you eat? So a meal that's high in carbs and low in fat is going to go through your stomach a lot faster, especially if you have any alcohol or caffeine, because remember, alcohol and caffeine increase gastric motility and secretions. And so you'll notice you'll be hungry sooner, which is why it's good to have fat in your meal. The more fat in your meal, the more full you will feel later. And liquids will always go through our stomach and get absorbed much faster than solids. And then the amount of food. If you eat more food and you stretch your stomach more, it's going to have more vigorous contractions as well. So it would increase the motility of the stomach. We also know that for body position, because the stomach is over on the left side of the body, that if you lay on the left side of your body, on the left side may actually decrease gastric emptying. I've also seen that if you're lying on your left side where your stomach is, it keeps your stomach below the esophagus. So there's been some evidence that if you get a lot of heartburn, that it would be better to lie on your left side. If you lie on your right side, then it's more likely to get some of that heartburn. We also know that we talked about emotions already, that emotions can definitely affect our stomach. We know that with depression and sadness, it usually is inhibitory and suppresses stomach motility and stomach juices as well. And then there's some other things here that you can just read on your own. Obviously, when we exercise, we're not emptying our stomach as well either. Now, there's two reflexes that you see. They're called the gastroenteric and gastroileal. So when food hits your stomach and it stretches, these are stretch reflexes. So it's stimulated by the stretch in the stomach by food. The gastroenteric reflex basically is going to increase activity in the small intestine. And the reason is that food's in your stomach and the next place it goes is the small intestine. So it's basically going to stimulate the small intestine to kind of move the contents of the small intestine out to make room for what's coming in from the stomach. And then the gastroileal reflex is going to open what's called the ileocecal valve. And this is a sphincter between the small intestine and the large intestine. And when that valve opens, that's going to help move the small intestine contents into the large intestine, which usually will trigger defecation. So a lot of times in like pets and even kids, until we get on a regular schedule with bowel movements, a lot of times it'll happen after a meal because of these reflexes. And then we're going to wrap up today's lecture with vomiting. So not going too much into this, but we know that if we have any sort of disease process going on, our digestive system is going to just get rid of whatever it is, right? So it will either use vomiting, or we'll talk about diarrhea to get it out. But you can see all different causes. It can be hormonal, obviously food poisoning, pathogens, stomach flu. Pain can do it as well. Sometimes it happens with a heart attack. And so as far as vomiting goes, it's basically reverse peristalsis. And so what you're going to do is they call it anti-peristalsis, but the stomach contracts and forces the contents out. And then when we have excessive vomiting, we really worry about dehydration. And, you're losing a lot of hydrochloric acid. You're losing a lot of acid. So if you're losing too much acid from excessive vomiting, it could send you into what's called metabolic alkalosis because you're losing so much of that acid. So this wraps up our lecture on the stomach.